I'm really pleased to share with you the results of our efficacy and safety of intravenous Efgartigimod in adults with primary immune thrombocytopenia, the results of the ADVANCE-IV, which is a phase 3 multi-center, double-blinded, placebo-controlled clinical trial. So just a little bit about primary immune thrombocytopenia. It's an acquired autoimmune disorder which is characterized by a reduction in platelet count. And low platelet counts result in increased risk of bleeding. This is a systemic autoimmune disorder, and it does result in fatigue. You combine that, and you get a decreased quality of life for these patients. IgG autoantibodies, which are able to be detected in most patients with ITP, actually target and bind to glycoproteins expressed on the platelet surface, as well as the surface of megakaryocytes. Current treatment options for ITP, while are many, can be associated with comorbidities, unsatisfactory efficacy and duration of effect. They can have a limited impact on quality of life measures. So there is a need for better ITP therapy. So Efgartigimod, which is our compound, competitively inhibits the neonatal Fc receptor. And just a quick reminder about what that biology is. So in general, the neonatal Fc receptor is going to bind to native IgG. When native IgG is bound to the neonatal Fc receptor, it is protected from lysosomal degradation. Efgartigimod will preferentially bind to the neonatal Fc receptor, preventing the IgG from being able to bind. In preventing the IgG from being able to bind, more of it is transported into the lysosome for degradation, and less of it gets recycled into the peripheral circulation, thus decreasing the levels of these pathogenic IgG autoantibodies in ITP. The majority of these patients that were in our clinical trial had been exposed to multiple prior therapies for their ITP, and they all had long-standing duration of disease, what we refer to as a chronic refractory population, which tends to be notoriously difficult to treat. So the mean time of since diagnosis for these patients was about 10 years. They had 68% of the Efgartigimod group and 64% in the placebo group had received 3 or more prior therapies for ITP. What we found is that Efgartigimod demonstrates an early and a sustained increase in platelet counts when compared to placebo. 38.4% of the Efgartigimod treated participants compared to only 11% of placebos reached a platelet count of 30,000 at 1 week. And this 30,000 is the threshold at which we expect our patients not to experience significant spontaneous bleeding events. In those patients that received a sustained platelet count response, 9 out of 10 of them were able to go from weekly to every other week dosing on the drug, which shows that we can provide some flexibility in dosing schedules for our patients. When we looked at some subgroup analyses, one of the things that I think is very telling about Efgartigimod is that no matter what subgroup we looked at, it showed a benefit over placebo. So patients were splenectomized or non-splenectomized, patients who had had less than 3 or more than 3 prior ITP therapies, the length of time since their diagnosis, where they lived in the world, United States, Japan, Europe, the rest of the world, whether they were younger or older, and patients who are older notoriously are difficult to treat, and then whether they had received prior rituximab or prior thrombopoietin receptor agonists. None of these things influenced whether or not patients were going to respond better to our Efgartigimod than they did to placebo. From a safety perspective, it was well tolerated. There were no safety signals, and all of the treatment emergent adverse events were consistent with other Efgartigimod studies. One might wonder and worry about an increased risk of infection if we're decreasing antibody levels, but this was not noted in this trial. So the benefits of targeting the neonatal Fc receptor and lowering total IgG levels have been demonstrated by both clinically and statistically significant improvements in platelet counts compared with placebo. The drug was well tolerated. Most adverse events were mild to moderate, and there were no new safety signals. The results of this study showed us that we have some flexibility in dosing with both weekly and every other week administration, and over 90% of the patients who completed the advanced IV study have enrolled in the open label extension, which will give us an opportunity to continue to evaluate durability of response as well as safety. Thank you.